You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is September 20th, 2024. Our topic is Asthma and Allergies in Pregnancy. This is presented by Dr. Karen Blatman. She's a Section Chief and Program Director of Allergy and Clinical Immunology at Dartmouth Geisel School of Medicine.
Yeah, I'm Karen Sue Blatman, and I am the Fellowship Program Director and the Section Chief at Dartmouth Medical School, or it's the Geisel School of Medicine at Dartmouth College, and the hospital that we work at is Dartmouth Hitchcock Medical Center. And I want to talk to you guys today about asthma and allergies in pregnancy. Let's see. All right, so the learning objectives today is we're going to go over and review some of the maternal physiologic changes, and then we're going to review some of the potential maternal and fetal consequences, and then of these uncontrolled symptoms during pregnancy. We will then talk also about risk and benefits of some of the common treatments that we're going to give as allergists during pregnancy. I don't have any disclosures that are relevant to this talk. So during pregnancy, starting during the first trimester, we're going to see minute ventilation increase to 50% due to increase of tidal volume. The primary mechanism of this is related to progesterone, and that will increase the respiratory sensitivity to carbon dioxide. And the progesterone levels are going to rise from about 25 nanograms to at 6 weeks to 150 at term. And what that does is that changes that setting of the CO2 kind of how the baseline in the thalamus. So looking at the arterial blood gas and acid-base state, pregnancy is respiratory alkalosis. That's a secondary compensation through renal loss of bicarbonate, and we're going to have higher PO2 and a lower PCO2. That lower PCO2 is going to provide a diffusion gradient that may facilitate the fetus's ability to eliminate waste from aerobic metabolism. So changes in the pulmonary function test during pregnancy is that you're going to see that there is an increase of tidal volume and a decrease of residual volume, and ultimately a functional decrease of functional residual capacity. And we're not going to see any changes in either the FEV1 or the ratio of the FEV1 to FVC. Fetal oxygenation. The arterial PO2 in the fetus is only a quarter of the arterial PO2 in the adult. And in the placenta, maternal and fetal blood is going to run parallel to each other through the placenta. Fetal umbilical vein PO2 can never exceed the maternal placental venous PO2. And so due to placental inefficiencies, the highest fetal PO2 is always going to be less than the lowest PO2 in the mother, and the mom is going to compensate with a high perfusion rate. And so this is going to get into why the OBs and are going to care so much about us making sure that their asthma is well controlled, because it really does. It's all about affecting the baby's ability to be able to grow. So the reduction in uterine blood flow, vasoconstrictors, hypotension is going to compromise your fetal oxygenation. And the fetus is going to compensate that by redistribution of circulation to the vital organs and decreasing the gross body movements. And so that response to the chronic hypoxia is deferment of growth. So these fetuses are going to be small. They're going to be small for gestational ages. This is a normal part of pregnancy, so 60 to 70% of women are going to experience some sort of air hunger during normal pregnancy. That will start around the first or second trimester, and the frequency will rise in the second trimester. It'll be worse in the sitting position, not associated with exercise. It's a gradual onset. These patients are not wheezing or coughing, though sometimes this dyspnea can be quite severe. There's also rhinitis of pregnancy, and these are patients with nasal congestion. And it's a normal part of pregnancy, and it typically will present in the second trimester, resolving within a couple weeks after pregnancy. And typically this is once again related to progesterone, the hormones, your increased blood volume, increased serum placental growth hormone, and there's some decreased albumin in pregnancy that will lower the vascular oncotic pressure. And this is the reason why it's important to understand asthma in pregnancy, because it is the most common potentially serious medical problem to complicate pregnancy. About 8 to 9% of pregnant women have reported asthma, and this is looking at the timing of 2000 and 2003. There's another study in the UK that showed that exacerbations occurred in about almost 5% of pregnancies. So I have a lot of times when I'm chatting with patients, we will say that about a third patients will stay about the same or get worse or be better. I've had a couple patients that really seem to be better during pregnancy, but I would say the majority of the people that are referred to us are going to be patients who either currently have asthma or will have worsening of symptoms during pregnancy. And those who do have worse symptoms or that we've seen will revert to their pre-pregnancy kind of status a few months postpartum. What are some of the causes of worsening asthma? One of the things I do want to talk about today is that patients are worried about affecting their pregnancy. They are worried about they don't want to make the pregnancy worse. They don't want to harm their fetuses. And so sometimes patients will then just stop certain medicines. Or there are also physicians or providers who may end up undertreating asthma during pregnancy. But what is really important is actually to really keep the asthma under control because of what we just talked about before. The timing of flares will happen typically the weeks of 17 to 24 weeks, which is the second trimester. And what's so interesting to me is that flares, you're going to have the fewest symptoms in the last 4 weeks of delivery, and it's very rare to see asthma flares during their time on labor and delivery. And we don't quite understand why. This is a nice up-to-date graph that I pulled looking at the frequency of asthma attacks, and we see that most common in that 17 to 24 weeks. What are the adverse outcomes for patients who are having difficulty with asthma? They could have miscarriage, fetal death, neonatal hospitalization or death, congenital malformations, cleft lip with or without a cleft lip, a palate, reduced fetal growth, and impaired function of developing organs. Perinatal outcomes. So the maternal asthma may increase the perinatal complications, and we talked a little bit about the IUGR earlier. And then there's also preeclampsia, preterm birth, and low birth weight. And that most common mechanism is due to hypoxia. One of the expert panel reports, this is now back in 2007, is that it is safer for pregnant women with asthma to be treated with asthma medications that we may not know, we may not have really great safety data, versus having asthma symptoms exacerbations. The hardest thing about pregnancy is a lot of companies don't have studies on medications for when patients are pregnant. So what do we do for patients who are pregnant? We will do monthly evaluations of asthma history and pulmonary function, and sometimes that's just alternating with the OBs to kind of check in and just see how their asthma is doing. An initial visit, it's nice to be able to get a baseline spirometry, and at subsequent visits, we may not need to do formal testing. And then if patients are having really significant asthma, the OBs may do serial ultrasounds starting around week 32 to just make sure that they're able to check on the baby, and monitoring of fetal movements is also encouraged. So adherence to medications, this is where I kind of alluded to this earlier. There's been several studies looking at this, that when there's patients who've had asthma exacerbations and they've been evaluated, for example, by Murphy et al., looking at 146 pregnant women, 29% of them occurred due to non-adherence to inhaled corticosteroids. The use of control medications can be decreased when rescue medications are increased. So I think that when we get the history that someone is using a lot of their rescue inhaler, it really warrants us to be able to ask, are you using an inhaler for a controller medication? And then during 1990 to 2002, looking at 4,434 asthmatic women, there was a French study that basically looked at this, and 50% of these patients stopped or reduced their inhaled corticosteroids during their pregnancy. What's also our general approach to the allergy side? So we definitely would be thinking about allergy avoidance and just doing kind of things that are non-medicine. And we would evaluate anything that is concerning with, if we're worried about anaphylaxis due to just a systemic reaction with skin testing, we may try and do that either before pregnancy or postpartum. The things that we would really want to do during pregnancy would be things that might affect pregnancy. For example, being able to understand if someone still has an allergy to penicillin, or sometimes I get asked about other medications that they might use during delivery, such as local anesthetics. And since it's very rare for patients to have an allergy to local anesthetics, and it really does affect their time during labor and delivery, we are often doing testing for some of these medications during their pregnancy in preparation for delivery. But things like either environmental allergens or things like that, we would usually wait to do the skin testing. For rhinitis, I like to talk about, starting off with even some things that are non-medical or non-medicine, such as saline irrigations, making sure that they remember that they have to either boil the water or use distilled water in those irrigations, and that physical exercise is also a way of vasoconstricting. And I like also adding adhesive strips onto the nose to sometimes dilate that in that area. Allergy shots. So we will typically, at least here in our practice, and I believe that this is also in the parameters, is we typically won't initiate immunotherapy during pregnancy due to the possibility of systemic reactions or anaphylaxis. But we will, for patients who are already on maintenance, we will continue them on that maintenance dose as we are, I feel like we in general have figured out that, while it's not 100% that they won't have a reaction, that they certainly have proven that they've been able to tolerate that dose. And then if for some reason they do get lost to follow-up, or they have to decrease their dose at some point, we may not titrate or increase the dose during the pregnancy and just kind of keep them where they are. I think that if this is one of the things that's maybe important to talk about as we're getting to start allergy shots, that to understand that if we think that someone may be planning on pregnancy, that we may want to wait to start after postpartum. Anaphylaxis in pregnancy, um, there are mast cells in the walls of vagina and the uterus, and so patients may present with low back pain, pruritus, cramping, and possibly preterm labor. Fetal distress could happen if it was a significant anaphylaxis. And if someone's presenting with laryngeal edema, we also have to think about that preeclampsia can have a presenting symptom with that, and patients with hereditary angioedema could have laryngeal edema. And then in terms of hypotension, one of the things that's interesting that is quite rare is something called amniotic fluid embolism syndrome. And this is thought to be a non-IgE mediated reaction to fetal antigens. And if a tryptase was checked, it may be elevated. I want to talk a little bit about pregnancy and teratogens, and just some kind of general numbers for you to consider when we compare to other medications and using medications. In general, the major congenital malformations are about 2 to 4%, and there may be another 2% that don't become apparent until they're about a year old. And then there's minor malformations to 10 to 20% of children. Genetics are going to be the etiology of about 25% of these malformations. And then there's about environmental is 10%, of which medications is going to be 1 to 5%. And then the vast majority of congenital anomalies remain unknown. These I just wanted to share with you are some of the different resources for understanding some of this information, and some of it may be attached to your EMR. I want to briefly address these old FDA categories. They are no longer used. There's a different labeling system in the last decade, but I just wanted to bring them up because sometimes you'll still see them every once in a while. So almost no medications are under the category A, which is that there's controlled human studies that have demonstrated no fetal risk. And this was created in 1979 to try and give some sort of information about potential risks. Category B is animal studies don't indicate any fetal risk, and there are no human studies, or there may have been some adverse effects in animals, but not in human studies that have been well controlled. There is category C, where there's lots and lots of medicines that fell into this category, was that essentially there was either no adequate human or animal studies, or there were some adverse fetal effects, but no available human data. Category D was an evidence of fetal risk, but benefits outweighed risks. And category X is evidence of fetal risk, and the risk did outweigh any benefits. So the system went away, and partly because there was this tendency for people to be like, oh, category B is better than category C. But category C really just meant that we didn't have any information. So, for example, albuterol is a great category C example that we use it all the time in everybody, including pregnant women, but we don't have any human studies available to support us using it. So the current labeling rule started in 1997, and essentially is currently in place. They removed the letter categories, and they really tried to talk about just kind of giving more data. It's actually harder for us to kind of, it was easy to have a letter label. Now we have to do probably a little bit more reading and discussion with patients on what this means. The new labeling is organized in 3 different subheads: risk summary, clinical considerations, and data. And the information about the existence of a pregnancy registry is also required, and there's some that I will talk about in a little bit. Over-the-counter drugs are not affected by this rule, and drugs that were previously approved have to comply, and so at this point anything that is available would have to comply with this labeling law at this point. just wanted to show briefly, we don't have, I don't have a lot of, I don't have the prescribing information for different antihistamines, but there is a lot of antihistamine use in pregnancy. And I just wanted to show, oh, I don't have, oh shoot, I am going forwards. So I just wanted to show, I'm sorry, it's a Jackie in Practice article in 2013, and this just shows the use of a lot of different antihistamines, and just to give you a sense that that patients are using these medications in pregnancy. And I would say by and large, the antihistamines, we have not seen any major adverse effects of antihistamines in pregnancy. So this is what it looks like now. I pulled up mepolizumab, and it basically will tell you that there is a registry that has been available to patients who have been on mepolizumab during pregnancy, and that and it gives you some information about how to enroll in that. And then there tells you a little bit about a risk summary, and it tells you, it mentions that all monoclonal antibodies such as mepolizumab are transported across the placenta in a linear fashion, and so potential effects on the fetus might be greater during the second and third trimester of pregnancy. And then it tells you that that in a study of monkeys that there was not evidence of fetal harm of IV administration of mepolizumab, and then it compares that against the general population of the background risk of birth defects and miscarriages in these recognized pregnancies. And then it also says it has on the bottom a disease-associated risk in that women with poorly or moderately controlled asthma, that there is the increased risk of these particular diseases, such as preeclampsia in the mother, and then also low birth weight and small for gestational age in the neonate. And so it does give you I think it gives us more information to be able to make some decisions. So omalizumab, it previously carried the label of pregnancy class B. We know that there's limited animal data that suggested that the risk was low. It does cross the placenta during the second and third trimesters. And we were able to, based off of the EXPECT pregnancy registry, it enrolled 230 patients with telephone interviews with patients who were already on and stayed on omalizumab during their pregnancy. And they found that there was a rate of I'm just going to show the table in the next slide. And what's interesting is about 5 years ago, the European Medicines Agency and their public assessment report noted that they felt like omalizumab could be considered for asthma treatment during pregnancy. So here's a nice table about the EXPECT registry. So the cohort on the first column is the patients that received omalizumab, and then they compared that against the Quebec Asthma and Pregnancy Database to use as a comparison. And you can see that in terms of the percentage of patients that had a congenital anomaly are similar, and then essentially the percentages of the anomalies is well below or within the range of the Asthma and Pregnancy Database, which shows a general population and the percentage of anomalies in that cohort, which included about more than 1,000 patients. So The Vaccines and Medication Pregnancy Surveillance System is designed to monitor the use and safety of vaccines and asthma medications during pregnancy. And this is a collaboration of the QuadAI and with some of these other resources, including the Research Center at the University of California, San Diego, and Boston University, and the organization Otis Research Center. Oh, that's at San Diego. And so this number is the number to refer to the pregnant asthmatic patients, and there's been some ongoing studies that you can search for on the website. I wanted to talk, transition over to decongestants and talk about that they are all vasoconstrictive, and we don't know if these cross the placenta, but because there is the alpha adrenergic stimulation, it can cause constriction of uterine vessels and cause possible vascular disruption. So these medications are not, we don't recommend them during pregnancy. There have been some retrospective studies. One of them is looks at mothers with 206 infants with gastroschisis and 126 mothers of infants with small intestinal atresia, and there was an increased risk of having been exposed to pseudoephedrine during gestation. And there was a risk for gastroschisis was increased further among infants who had been exposed to both the pseudoephedrine combined with acetaminophen. The risk of small intestinal atresia increased for any use of pseudoephedrine and for the use of that also in combination with acetaminophen. I think the biggest concern is related to the vasoconstrictors. So the American College of Obstetricians and Gynecologists and the college recommend oral decongestants be avoided during the first trimester unless the expected benefit is large and unique. So what that means is that I spend time talking to my young women or women of childbearing age, and we talk about how our preference is not to kind of grab the oral decongestants. Once in a while is one thing, but it's another to have it kind of on a regular basis, on a consistent basis. Oral steroids is something that patients might ask you, and we have looked at data from animal studies that initially they suggested that their high-dose steroids might lead to oral facial cleft. The lip formation happens during weeks 5 to 7. There's palatal closure complete by 12 weeks of pregnancy. But what we found is that prednisone is the preferred choice because placental enzymes do limit that passage to the embryo. And there has been some, I think, further population studies. There's a population-based study in Denmark with more than 51,000 patients that had corticosteroid-exposed pregnancies, and they did not see an increase of these oral facial clefts regardless of the type of corticosteroid. And another thing to think about is that actually after the completion of the placental development, all corticosteroids are partly inactivated by these 11 beta hydroxylases of the placenta with relative protection of the fetus. So I think I have given steroids during pregnancy. And then there's a most recent and largest case control study from the U.S. National Birth Defects Prevention Study that didn't show any increased risk for oral clefts with first trimester steroid use in any indication. And so I know that we don't. This is not all. This is not all the information, but I feel that this supports using steroids if we need to. There's also this talking about the safety of inhaled corticosteroids with patients. And certainly I would much prefer to give someone inhaled corticosteroids than oral steroids. So the budesonide is the most studied. And again, back before the labeling laws had changed, it was given a Class B designation. it doesn't mean that just because I don't have data on other inhaled corticosteroids means that it's less safe than budesonide. And so typically, if patients, whatever patients are on, I usually like to continue with whatever they've been on, so that we're not having a concern where we're, during transition, we're having more symptoms, because that will affect the fetus. It is not known if either fluticasone or mometasone will cross the animal or human placenta. The molecular weight is low enough for passage, but again, I think that there's very low systemic bioavailability, so that would suggest that if very little of that medication will reach the embryo or the fetus. What about nasal steroids? So there's an interesting article that was published in 2016 that showed that that triamcinolone nasal spray, this would be the brand name Nasacort, may increase the risk of respiratory system defects. This is based out of looking at 5 cases out of a cohort of almost 300,000 pregnancies in a database based out of Montreal. And so initially, which is interesting, because I don't have this kind of just because I don't have this kind of information for the others, it makes it's hard for me to interpret this data, but because of this article, I will usually prefer ordering something else. We have fluticasone, we have budesonide, we have mometasone, and so in general, I would prefer to prescribe this everything but the triamcinolone, but it also, it's if someone's doing very well on triamcinolone, it's hard to have a discussion about switching to a different nasal spray. And then due to 3 large Swedish birth registries in 2004, when they were still using the old labeling system, they felt like there was good data to kind of upgrade the budesonide letter labeling from C to B because of these birth registries. Epinephrine. Sometimes patients will say to you, can I use epinephrine? Are there problems with epinephrine? And I think that concern is due to that potential, we can potentially reduce uterine blood flow in the placenta. The only thing that, interestingly enough, that we've seen that has been associated with epinephrine use is an inguinal hernia. And so I think we think that most likely, if there is issues with infant deaths or other abnormalities associated with maternal epinephrine treatment, that it's more likely due to fetal hypoxia that was related to the underlying anaphylaxis that we were trying to treat. These were the sheets that I wanted to mention, that if you go to mothertobaby.org, there are these fact sheets about all these different kind of medications, and I think it's a wonderful resource if that you can share with your patients. So my conclusions today are that asthma during pregnancy have been associated with some adverse prenatal outcomes, and the poor asthma control and severe asthma can be associated with adverse prenatal outcomes. Most of the available data for asthma medications has been relatively reassuring, including systemic steroids. Avoid decongestants during that first trimester, and I can tell you that is something that is very important for us to talk about with patients who are anticipating or thinking about pregnancy. And the registry data can be helpful for biologics. We really are still, I think, collecting those. We have very little information about other biologics outside of omalizumab, and I think that we will continue to learn more about those medications as people use them, and hopefully we'll be able to get registry data on them. All right.